I'm Cindy Moorhead, the co-president of the Lake Forest Lake Bluff League of Women Voters. I'd like to welcome you all to this evening's program on health care, sponsored by the League of Lake Forest Lake Bluff and the League of Women Voters of Lake County. The League of Women Voters is a nonpartisan political organization that encourages informed and active participation in government, works to increase understanding of major public policy issues, and influences public policy through education and advocacy. In 1990, the League of Women Voters US undertook a 2-year study of the funding and delivery of health care in the United States. The LWV-US announced its position in April 1993. Since then, the League has been advocating for health care reform to all administrations. The health care position outlines the goals the LWV-US believes are fundamental for U.S. health care policy. These include policies that promote access to a basic level of quality care at an affordable cost for all U.S. residents, and strong cost control mechanisms to ensure the efficient and economical delivery of care. I'd like to introduce now Phyllis Albrecht, who is a past president of our league, who will be the moderator this evening. Phyllis?
Thank you, Cindy. Our 3-part program tonight begins with the viewing of a film entitled Health, Money, and Fear. This film was produced by Dr. Paul Hochfeld, an emergency room physician. The film will be followed by presentations by 2 panelists, whom I'll introduce in greater detail later on, but they are Jonathan Vanderbrug, who is the Director of Campaign for Better Health Care, and Courtney Hederman, an Associate Director of AARP. A question and answer period will follow the panelists' presentations. Cards will be handed out to those individuals wishing to submit questions to our panel. Questions will be collected by volunteers following the movie. I'm happy to be serving as your moderator tonight, and we'll begin with the movie.
There's a lot of things we could say about our system. It's not working.
Labyrinthine.
Irrational. I think best describe it as embarrassing.
We're doing too much, and it's way too expensive.
A chaotic system.
It's a hodgepodge of business arrangements.
An embarrassing disaster. It's not working.
It's unsustainable.
And most importantly, in my opinion, it's unethical.
I've been an emergency doctor for almost 3 decades. It's been a good run. I've helped a lot of people, and I'm a little ashamed to say that I've made a very good living working in a system that's as much about fear and money as health. We have over 40 million uninsured Americans, and while Congress seems to think they can find votes in talking about what we call universal access, they're more focused on the symptom than the problem. It costs too much. The important questions are, why does health care cost so much, and what can we do about it?
Medical inflation has outstripped general inflation by probably 50% over the last 10 years. Cost of health care is the second leading cause of personal bankruptcy. Average family premiums now exceed the gross annual income of a full-time minimum wage worker. It's probably the single leading barrier to economic growth, but I think most chilling is the implications of the growing cost of health care on the fiscal solvency of this country. And while Congress is worried about Social Security, that's about a $5 trillion problem. Medicare increases with medical inflation, and when my generation fully reaches the age of 65, it starts in earnest just 5 years from now, in 2011. The unfunded entitlement in the Medicare program exceeds $65 trillion, and we're financing that by selling securities to Japan, China, and other countries that are still willing to purchase them. My sense of urgency here has nothing to do with health care as much as the fact that the window in which we can act and shape our own future is very narrow and narrowing rapidly. And we don't have time to wait for Congress to somehow fix this for us. We need to figure out a way to jumpstart this debate, and we need to do it now.
We have the world's
most expensive healthcare system. This year we'll spend more than $7,000 for every man, woman, and child in the U.S. Just under 60% of all health dollars in the United States pass through the hands of the government. And in that 60%, I would include something called the tax subsidy to private health insurance. That is the money lost to the federal treasury because health benefits are not taxable to the employee as income. Our government is already paying an amount equivalent to the total spending per capita in other nations, and then we go and take another $2,500 out of our pocket privately. It's ironic because despite spending twice as much as people in other countries, we have 46 million uninsured Americans. We have tens of millions more Americans who have only partial coverage. That is, they go out and they buy health insurance in good faith, thinking it'll cover them when they get sick, and then they get sick and find out that their health insurance is full of gaps like co-payments and deductibles and uncovered services, so that even though they have health insurance, they still face financial bankruptcy in the event of a serious illness. We're getting very, very poor value for money for what we spend on health care. The way the history is usually told is that in the early 20th century, healthcare was not terribly expensive, but during the Depression, many people had difficulty paying out of pocket for health care.
It started really growing during World War II, as employers saw this as a way to increase wages in an environment of wage controls, that it was okay to throw in a health insurance plan. Private health insurance grew. It became apparent that one group that didn't have insurance was the elderly, and that led to the Medicare program. So, you know, we had the same system which started out as a system for people paying their own bills, and all of a sudden a third party entered the system to pay the bills. Whether it was because of the way science and technology was evolving or because of the stimulus of third-party payments, there were a lot of new things to pay for, and there was no constraint. Of all the drivers of rising costs, technology is just the dominant one. And it's something you can't complain that much about because a lot of the technology is useful. Now, a lot of it is marginal, but the other factors which are often raised, such as demographics, aging baby boomers, compared to technology, they're really not that big a factor.
Well, one of the profound American commitments has been to scientific progress, and healthcare has very much latched on to that tradition. What we have is what I call an infinity model, that no matter how far you go with medical progress, there's always further. Whatever you invent this year, you can reinvent next year to get a better product. So it's utterly open-ended. And if everybody lived to be 150, the emergency rooms would still be full. The doctors would be talking to patients that are complaining about pain and suffering and keep me alive, doctor. Everybody loves it. The liberals love it because they're children of the Enlightenment. The right likes it because you make a lot of money. One of my favorite sayings in the 19th century, Samuel Gompers, a labor leader, was asked what labor wanted, and he said, more. And I think if you talk to medical researchers, what are you looking for? More.
You get into an area that I think has an impact that the public's not generally aware of, but I refer to it as the 2T effect, technology and tort reform. Let's use your description of the MRI. When the MRI technology became available to us in the field, then people said, I want to have access to that when I need to have access to it for the patient's best interest. But because it was such good technology, it almost became a tool to be used to rule out whether there was something there or not necessarily to diagnose what was. And because of the tort system, the legal system, saying that, doctor, you have a duty to perform to the highest level of care, and if you don't, you're going to be held accountable, and the institution's going to be held accountable, then people started to order them more frequently.
I actually went to law school with the hopes of maybe ascending into hospital administration. In my medical practice, and I know this is true with other practitioners, every time they see a patient, they're in essence doing two things. They're trying to reach a diagnosis, and they're trying to care for the patient, but they're also trying to build a case, their own defense case, in case something happens. Because what actually happens now is that any bad outcome, the patient now becomes a plaintiff, is looking for someone to pay for it. The idea is that every problem is fixable. You should have fixed it. If it wasn't fixed, there's something wrong, and I should be able to sue you for that. And as a result, we order test after test after test. We do everything possible because in the backs of our minds, we say, I can hear that plaintiff's attorney saying, and doctor, why didn't you order this CT scan of the abdomen?
It's actually dangerous to patients. We now know that because of the number of CT scans being done, that probably somewhere in the neighborhood of 2% of the fatal cancers in the next 10 or 15 years will be as a result of excessive use of CAT scanners.
So we order all those tests, not because we think they're going to produce anything, but because we're afraid that if something terrible happens, we'll be criticized for it. So am I part of the problem? Yeah, sure I'm part of the problem, because I'm afraid of being sued.
We estimate that to be 10 to 15% of unnecessary medical care delivered to patients purely from the physician's fear of a malpractice situation.
There are places right here in Oregon where you cannot get obstetrical care because of the medical malpractice. These obstetricians are dropping that part of their practice and just practicing gynecology, and that's also a real problem. So any system, I think, has to address that question. Now, our counter argument to dealing with medical malpractice is people need access to justice, and I don't disagree with that. I don't think they're mutually exclusive. But there's a lot of ways people lose access to justice today. One of them is a system that forces you to have a stroke before we'll manage your hypertension. So we need to step back and put all of this into context and recognize that what we have doesn't work for anyone.
In the last 20 years, the business model, hospitals trying to make money, competing for patients, insurance companies trying to make money off of us, we've become more of employees rather than independent practitioners. And as a result of that, we have managers, and the managers are starting to put pressures on us. You need to be more productive. You need to have, I get a score every 3 months telling me the number of RVUs per hour that I produce. Okay? And if I'm in the lower half of my group, I need to pump that up. I need to either do more tests. I have no control over the number of the kinds of cases that come into my emergency department, but I know that I can pump up my RVUs per hour by doing more tests. So a chest pain that I think is an inconsequential chest pain becomes an important chest pain if I do a whole series of tests, and that pumps up my RVUs per hour. Do I do it? I hope not. Am I pressured to do it? You bet. You bet. And so the pressures are there, externally placed many times by business people who have imposed their will upon healthcare and are pressuring us into more of a business model. And I think it's damaging to the interaction with patients as people, and it changes how fundamentally who we are. Because everybody's always said doctors are not good business people. That's a good thing. That's a good thing. We shouldn't be good business people. It's not a business. It's about caring.
In the real world, this is how this works. Let's say you bring your son to the emergency room, you hit his head, maybe he was confused for a few moments. Your expectation is, I'm going to get a CAT scan. My choices are two. I can either just order the CAT scan, which adds to my RVUs, or I can engage you in a time-consuming, sometimes awkward conversation about why I wouldn't get a CAT scan if this were my son, Nick. In the end, I'll offer the CAT scan anyway, because after all, it is your child. If we don't get the CAT scan, I've accomplished three things. I've increased my liability, albeit small. I've taken more time, which stresses everybody, and I get paid less for the encounter. Why I continue to have these conversations with people just doesn't make any sense.
There are a few scoundrels out there, but most doctors see a sick person in front of them, they want to help them get better. I think that's true. But I want to talk a little about human nature here, okay? You're the kidney doctor, you're giving the patient dialysis, and by giving them an EPO shot, you can get paid even hundreds of dollars more. If it's a close call and one decision's going to raise your income and one's going to not, maybe you're going to make that call and say, okay, give them the EPO shot. Even more dramatic in the case of a heart specialist who's doing a cardiac cath. They're shooting dye through the coronary arteries to see if there's a blockage. They see a blockage there. Now, this latest study would say if they have chronic stable angina, you stop right there, pull the catheter out, and you start medications, diet, and exercise, and they'll do just as well. But it's just human nature. You're sitting there, you've got the catheter in there, and you can reach over and get a stent and put it in about 90 seconds and get paid $2,000 for it. No one's going to put one in that they're sure is unnecessary, but what if you're sitting on the fence? Human nature says you're going to reach for that stent and make the extra $2,000.
Prescription drugs still account for just a small part of the healthcare dollar. The problem is that it's rising rapidly. Now, if you talk to the drug companies about this, they say, yeah, prices are high, we know that, ain't it awful? But they say we have to charge these high prices to cover our research and development costs. If there were to be any kind of price regulation, that would stifle innovation and we wouldn't be able to bring you all the medical miracles that we're now bringing you. None of that is true. None of that. From the beginning to the end, except the part about the prices are high. That is indeed true. If you look at just the top drug companies in the United States in 2005, their sales came to $222 billion. They spent $32 billion of that on R&D. But look at what they spent on marketing and administration. $71 billion, over twice as much as they spent on R&D. And after these expenditures, they even kept more in profits, $39 billion. Their profit margin was 16%, as compared with less than 6% for all the Fortune 500. So when they say, well, we have to recover our R&D, yes, but what you're really covering is your outrageous marketing expenditures and your obscene profits. That's what you're doing, and that's what all of these high prices are covering. When the FDA considers a drug for approval, it has to be found reasonably safe and effective. But effective compared with what? Now there is the loophole. It doesn't have to be found more effective than other drugs already in the market to treat the same condition. It merely has to be more effective than a sugar pill, than a placebo. In the absence of any data whatsoever, what the drug companies do is to promote these new drugs as though they were better. And that's what you see on the direct-to-consumer ads and the marketing directed to physicians. These drugs are usually targeting fairly minor conditions in essentially healthy people. Hard to define, vague conditions like social anxiety disorder or erectile dysfunction. These kinds of diseases that can be expanded with enough advertisements, you can convince every young man that he has erectile dysfunction. You can convince every man and woman that they have social anxiety disorder, because who hasn't been shy from time to time? I'm not somebody who believes that it's all the patient's fault. I think that they are vulnerable to the marketing hype, so they go to their doctor, and the doctor also believes what the drug companies have been telling him. So he reaches into his cabinet full of free samples of the very most expensive brand name drugs with long patenting lives ahead of them, and says, well, here, try this and see if you feel better. And gets rid of the patient in a hurry. It'd take longer to convince the patient that he didn't need a drug. And the patient feels, this is a good doctor, this doctor took good care of me because the prescription is proof of that, and it validated the ad, and the patient goes away with an expensive drug that he and the doctor are both hooked on from that moment on. When the free samples run out, he's still taking that drug. About $40 billion of their gigantic marketing budget is unaccounted for. So what might that be? I think it's marketing to doctors, but under a different name. It's education.
I find it humiliating as a psychiatrist to encounter the story which appeared in last week's New York Times about the payments made by drug companies to psychiatrists in Minnesota. If I recall, it was approximately that those doctors who had received $3,500 or more, as opposed to doctors who had received no money or less than that critical amount, were prescribing drugs that should not be given to children 3.5 times more often, being quietly on the take from the company that manufactures the drug that you're selling your patient, you're giving your patient, you're writing for your patient that he takes in good faith, makes the profession itself look so sleazy that it undercuts the basis for a trusting doctor-patient relationship. Nobody in my time did the things that occur now, because in my day, drugs for treating mental illness had not yet been developed in any large amount. So when I was a young practitioner, there were a few drug companies that found it worthwhile to buy my time. So if I didn't succumb to temptation, part of it was that there was no temptation then.
When I started out in medicine, which is now over 60 years ago, medicine was not viewed as an industry. Nobody called it an industry. Most people thought about medicine as a professional social service, and the name of the game was to provide good health care to everybody. Over the last several decades, things have changed, and we have huge numbers of investors owning and operating insurance companies, medical facilities of all kinds, and they're in it for the money. In 1963, Kenneth Arrow, who later won the Nobel Prize, published an article in which he explained very clearly why health care was not a market like other ordinary commercial markets, and why the laws of supply and demand didn't apply to health care. He points out that medical service is often defined by an illness over which you have no control. It may threaten your life. You may be scared to death. You may be incapable of exercising any judgment at all. You have to depend on the expert, compassionate advice of your doctor. And your doctor, therefore, doesn't act as a vendor. He or she is a professional and is committed to put your interests ahead of his or her own interests, to serve your interests first. That's not the way it is in business. After investor-owned businesses got into the hospital field, apologists for investor-owned health care said, maybe you don't like the sound of it, but we're really more efficient. We really know how to manage organizations, and we're giving consumers, that is patients, we're giving consumers a better deal for the money. Well, it's just baloney. Yes, there was some evidence that at first investor-owned hospitals spent less money because they hired fewer RNs and they cut corners wherever they could. But there was never any evidence that the result was lower charges to consumers, to patients. If you believe that it's good to take money out of the healthcare system and put it into management and to profits and stock dividends, then you can say there's some advantage. But I have the old-fashioned idea that when we spend money for healthcare, we ought to be getting health care. Doctors have inevitably been drawn into this. Many doctors think of themselves as businessmen.
Yeah, I think one of the key worries of hospital administrators today is the competition that their hospital is facing from physician-owned facilities, such as ambulatory surgical centers, imaging centers, endoscopy centers, or just, the ability of physicians to do more tests and procedures in their office. And why are they concerned? Because these are the most profitable services for the hospital, and Physicians are building facilities often in partnership with venture capitalists or private equity firms to go into these businesses to specialize in what's paid the best.
One of the big questions in healthcare right now is what happens if organizations only do the profitable activities in the provision of healthcare and leave other organizations like community hospitals to do the rest of it. How will the hospitals continue to provide the emergency services? How will the hospitals continue to provide the neonatal, the critical care, and the other activities that the public has to have at points in time?
Given the proliferation of physician-owned facilities, this may have some effects of reducing unit prices of those services because insurers are starting to perceive that they can squeeze some of those prices because there are so many places for the patient to get it. But experience in healthcare would suggest that any reduction in unit price would be scant comfort compared to the increase in the volume of services. The research on physician self-referral is just striking. The differences in the proportion of patients referred to for tests or procedures when the physician owns it than when the physician does not.
Primary care medicine, general internists, family physicians, general pediatricians are disappearing. It's a major crisis. The percentage of new physicians coming out of training who choose primary care is dropping precipitously. Why? Money. You can make much more money as a specialist than if you spend time examining and talking to patients.
It's interesting, if you look across the world, consistently meaningful investment in primary care results in significant improvement in outcomes and reduced costs. There's no question about that. And the United States as a whole has one of the weakest primary care systems in the world.
We've developed a culture that says we value more specialty care and high-tech care than we do taking care of preventative issues. As an example, nowadays you'll hear a lot about bypass surgery for heart attacks and stents being placed for heart attacks. But what you really need to do is start 20 or 30 years earlier than that and control people's hypertension, their high blood pressure, control their cholesterol, get them to lose weight and exercise more. There's no compensation for working with people to do that. There's huge compensation on the other side. We are wedded to and somehow enthralled by high-tech care. We will always need that. We want to have that. But so much of it would become unnecessary if you did preventative care.
So far, we've discussed a number of factors that contribute to the total and growing cost of health care: developing technologies, liability concerns, drug costs, the dwindling supply of primary care providers, and the pressure for profits that come from all directions. We have yet to talk about the single most significant cause.
Why does it cost twice that much in the United States? Why are we spending $7,000 when they're spending $3,500? And of course they have new medications and high technology and surgery in other countries as well. We have the world's highest paperwork and health administration costs.
Let's say I started an insurance company today, John's Insurance Company. What's going to happen is that the young, healthy people are going to figure out they're paying way too much, and the older, sicker people are going to figure out this is a pretty good deal. So what I have to do as an insurance company is I've got to spend a lot of money figuring out what your risk profile is so I know whether I'm going to cover you or not, which if I don't cover you, it sort of defies the whole purpose of insurance, if you will. I also have to feed a shareholder if it's a public company.
We tend to see a lot of waste in our healthcare system in administrative costs because we allow any kind of insurance and encourage multiple insurance products. That multiplicity of insurance products makes it complicated to decide what's covered and not covered when a hospital or a doctor gives health care. So you have to have software and billing forms for each different insurance company. Then they've got to have people to do the billing. And then the insurance company doesn't want to pay for anything that's not covered, so they reject bills. You have to have staff to go over the bills, and then you have to have staff to correct the bills and send them back. And then you have to have people to fight over the bills.
They're set up to collect premiums, pay out benefits, and make a profit. If you have a patient who's going to be with an insurance company for maybe 2, 3, or 4 years, but then will be changing insurance companies if they change their job, or maybe the job changes insurance companies, that insurance company has no long-term plan for that patient, no long-term involvement for that patient. So they aren't being interested, really, in any preventative care, anything that would prevent the patient from getting sick in the long term. They're only going to be interested in holding down costs for that short period of time the patient's in their system. And they have to make an assumption that patient's probably going to be leaving the system. In addition, they want to keep people out of their system who might be ill or who might have a chance for becoming ill. Because remember, they're set up to collect premiums, pay out benefits, and make a profit. You can't do that if you've selected a population that has a potential for becoming sicker than what you expected. So their job is really not to produce health. Their job is a financial model. I would offer that's a model, along with many other things in healthcare, we have to change.
An estimate of administrative costs that would be avoidable in a simple, regimented, single-payer system. 25% of total healthcare costs is one figure that's used for that.
It's undeniable that servicing the insurance industry adds substantially to the cost of health care without contributing anything to health, and they are at the core of the problem. That said, let's move our focus from them to us.
One of the strange things about our healthcare system is probably in the neighborhood of 60 to 70% of people who have either a Medicaid program or a Medicare program or commercial insurance don't realize the cost of that health care that they demand, and they often demand everything to be done for them because there's no cost to them that they can directly see. There is a cost to them, but they don't directly see it, especially in commercial insurance. They don't directly see it until they understand that these huge premiums they're paying are buying those services, whether they really need them or not. And it's not uncommon, unfortunately, to have people in those situations demand tests, demand medications, demand treatments that they don't really need, and in some ways probably aren't even good for them.
The sense of entitlement of getting anything that's possible and available because, quote, I don't have to pay for it anyway, is a major flaw in our thinking. Not only do we all pay for it anyway, it's driving the cost of health care to such an exorbitant level that none of us can afford basic health care anymore if we don't have insurance, which we're all paying for.
The other side of the coin of this is that 30% who have no access to health care, of those uninsured people going into the emergency room late in their disease process, costing a lot of money. That whole cost, again, is shifted back to that 60 or 70% of people who feel that they're getting their health care sort of free. They don't have to pay for it. But they see it in higher premiums, sometimes in higher taxes. But we're all in this together. And if we don't realize that, then we're going to continue to have a spiraling of our health care costs up and a spiraling of our outcomes down.
I've took care for about 20 years of a man who just died this week of lung cancer. He developed cancer that was already too advanced to operate on. He got radiation, he got chemotherapy. He was a man in his mid-80s, probably 86, 87 actually. So he'd lived a long life and he'd been healthy most of that life. He developed a brain tumor. Cancer spread to his brain. And really before I knew it, his oncologist had consulted a neurosurgeon and he had that brain tumor removed surgically. After about 4 or 5 months in the hospital, in rehab, he managed to get home, spent about 2 or 3 months at home, and then died. I think that was just an extraordinary waste of resources and a persecution of this elderly man. We probably spent $500,000 to $1 million to get those 2 or 3 months and most of them were spent in a hospital or rehab facility.
We have been under a huge amount of pressure by patients' family who have not been able to accept the inevitability of the death of the individual. At the same time, the incentives are there for the healthcare system and providers, whether the providers are institutions or individuals, to provide this care because of the reimbursement system, which reimburses quite strongly for those intensive types of services. And our expectations have to be much more realistic. Most individuals, when they really sit down and talk and think about it, are really more interested in quality. They fear more than anything else the debilitating stroke, ending up in a nursing home, ending up with Alzheimer's disease, not knowing who they are or where they are, not relating in a human kind of way with their loved ones. And yet, decisions are made over and over and over that do not reflect that goal. And when we draw from the public pool or from the medical commons, as Howard Hyatt has referred to, I think we have to be especially judicious in the use of these precious resources and limited resources when we apply them to end-of-life treatments that may at best only prolong the dying process and often lead to not particularly good quality of life outcomes.
Today, we ration healthcare by insurance status. Should we ration access to high-cost, low-benefit technologies? That's a difficult question.
There's now a general belief that the elderly are as good candidates for high-tech stuff as any other group of patients, which was not true 30 years ago because there used to be age limits. You didn't get bypass surgery after a certain age. You couldn't get on dialysis after a certain age. I found when I wrote a book on setting limits in the mid-'80s, I got in trouble because medical people say, well, you know, a lot of 90-year-olds have very good prospects. We can do the surgery. We wouldn't have done it 30 years ago. We can do it now, and we can maybe give them another 10 years of life. So the idea of setting any limits, I ran into enormous kind of resistance. It seems to me a good healthcare system is one that tries to help young people get to be old people, but not necessarily help old people to become still older.
Any one of us at any time could fall on hard times. And as a society, as a civilized society, we need to be willing to create a net to help one another. Because at that point we're talking about public dollars, and we're talking about what you and I are putting into the pot to help one another, the decisions about what those things will be, to what level and at what extent, need to be made by all of us. Not just me, a healthcare professional, but all of us as a society, because we are now talking about a societal help net to help one another.
You asked the question of whether the ills of our healthcare system reflect our society. Definitely, yes. When you compare for example, the American healthcare system with the Canadian healthcare system, you see a reflection of two different kinds of society with different values. The Canadians believe in cooperation, and they believe that their society has a responsibility for the welfare of the individual. We don't believe in equality as much as we believe in opportunity. The inequality of distribution of wealth is not important if it reflects the fact that some people work hard and deserve to get what they've earned. Health care can't be dealt with that way because anybody can get sick, whether they're rich or poor, and it can be a disaster. It can destroy your life, destroy your family, destroy your resources, take everything away from you.
The healthcare system does in part reflect the values of this community, or perhaps we might almost say non-community. That is the lack of concern of each for the other.
We are an individualistic, commercially oriented culture. One president said the business of America is business. And if you go back to American history, we were individualists. Thomas Jefferson, the less government is better government. So you've got this long historical thread that makes us where we are.
The reason that this show is being produced and I'm sitting here being interviewed is, you know, a basic assumption that the way our healthcare system is not a reflection of society's values, that this is not the healthcare system that society wants. It's one that is a result of history, political obstacles, greed, is the one that we've gotten now, and I think there are a lot of people very eager and who think they can improve it and to better reflect society's values.
I don't believe that Americans are born as greedy cowboys who don't care about the community and whose aim in life is to be richer than anyone else. That happens to many Americans because they're bathed in that ideology. We don't have education that's guaranteed as far as you can go. We don't have health care that is guaranteed. We don't have a secure old age. So the kinds of things that other countries do, we're left kind of naked. We're left vulnerable. And I think that that drives a lot of Americans to think that they cannot accumulate too much. That one serious illness, one tuition check for Harvard, old age, one broken hip could wipe them out. And so they've just got to stash away as much as they possibly can. They not only want to stash away as much as they can for themselves, but for their children and their grandchildren too. It looks like just unbridled greed, but I think it's partly something else too. I think for some people it is unbridled greed, but I think for many people it's fear.
Our system may or may not accurately reflect who we are, but we can do better. Other countries have models that get better outcomes for less money. It turns out we have a similar model in our own country.
The VA is very different culture. We don't have a consumer model. All of us who work there feel that veterans deserve the very best possible care that we can give them for the resources we have. 10 years ago, the VA realized they had to make decisions differently. Costs have been flat, outcomes have improved, and patients are more satisfied. While the community, outcomes worse, costs rising out of control, and patients less and less satisfied. Now, this is basically a single-payer system that's administered by the federal government. There's an explicitness to the VA that the private system just doesn't have. You don't know who's in charge out there. You have a sense that there's all kinds of people running around who must be making a lot of money. Their buildings are the best buildings in most cities. Their waiting rooms and lobbies are small palaces sometimes. My patients wait for many elective surgeries. But it's interesting, most of them can see, gosh, I am paying less. I get in to see my primary care folks. I have a very good acute care system. They made a much more significant commitment to primary care and better information systems. Every patient I see, their chart is in an electronic record. The record is available to me in the room I'm seeing the patient. I can see what everybody's doing in the VA system. It's extraordinary. They've also used their information system to dramatically reduce errors. They get the best deals on prescription drugs in the country. Part of that is because they have an information system and a primary care system that when they communicate, here's our strategy in prescription drugs, it gets done. And the pharmaceutical companies respect that.
It's important here to understand that Dr. Santa is talking about VA hospitals, not military hospitals, which have been receiving most of the bad press. There are people that are unhappy with the VA hospitals and the VA system, but they're unhappy with it because it's underfunded, not because it's a bad system.
This isn't about the healthcare system, it's about social determinants, it's about income. And that actually the healthcare system is a major regressive vehicle. It's making a lot of people very rich and a lot of people very poor. And so it's actually working to worsen the health of our population from a macroeconomic point of view. I mean, that's one reason why, for God's sakes, don't put more money into this. Because you're ruining, you're encouraging even more stratification.
Disease and illness does not distribute itself equally throughout the population. It remarkably distributes itself in a very uneven pattern, which is disproportionately affects the poor and disenfranchised. And it isn't because they have less access to medical facilities and medical care. It's because of all kinds of other confounding variables that go into that. The life expectancy, as you know, of black men living in the ghettos of Philadelphia or New York City is about equal to the life expectancy of men in Bangladesh. So I think one has to address that right from the very beginning. If you want a healthy society, you cannot have great inequities of wealth and poverty within that society.
There's a wonderful pie chart that you have probably seen called the determinants of health. Only 10% have anything to do with interaction with the U.S. medical system. We're extraordinarily good at turning a blind eye on all the social conditions that drive people into the healthcare system in the first place. And then once they're there, we ride in on the back end with all sorts of extraordinarily expensive technology and save them. But we have a system that doesn't try to prevent our people from becoming socially and metabolically bankrupt. That's wrong. It's not sustainable. It's not good for the nation, and it's not really what this nation is all about. I mean, this nation was founded on the promise of opportunity. And for an increasing number of people, the opportunity of upper mobility simply doesn't exist.
To do this is going to take, I believe, a political answer. I do not believe that this system will in some way self-correct, that you will see Medicare change because costs have gotten too high, that you'll see commercial insurance change because premiums are too high. I don't think that'll happen. You'll see an growing number of people who don't have health insurance. You'll see them flood our emergency rooms. It will drive costs in state government to the point that we can't fund other needed programs such as education, public safety, and the judiciary. Uncontrolled health care costs are now driving most state budgets.
Our healthcare system is sick because it costs too much. Some think we can save as much as 25% by adopting a single-payer system. We can save substantially with substantive malpractice reform. There are clearly some savings to be found with better coordination of care, avoiding duplication of services, and making fewer mistakes, all of which can be achieved by adopting a national electronic medical record. In addition, we can save by disallowing the mass marketing of prescription drugs and educating the public about end-of-life issues. Finally, we can find dramatic savings and get better results by paying our primary care providers adequately to do the preventive care we really need.
Our healthcare system is a bizarre blend of the worst of capitalism and the worst of socialism. It isn't a system at all. We need to get over our fear of the government and embrace the idea that in healthcare, somebody needs to be in charge so we can keep our eye on the prize, which is health, not profits.
In poll after poll, the majority of American physicians say the national health insurance system would provide the best care for the American population for a fixed amount of money. We need Congress to start listening to the American people who want and need national health insurance, and to stop listening to the private health insurance industry and the drug industry who are saying, don't do it.
I don't think we need more money in the system. You know, if money was equated with health, we'd have the best health population statistics in the world, and we're down right around Cuba right now.
Look to the historical track record of healthcare systems that work. The European systems have worked. They've held down costs. They're popular with the citizens.
Access is necessary, is important, but it depends on controlling costs, and you're never going to control the costs until you have a good, workable, single-payer system.
Congress, right now, you think that you can serve the pharmaceutical industry and the private health insurance industry, and the voters won't notice. But the one thing you need more than the money that these industries pour into your political campaigns is votes. And God help you if you ever find that the votes are going in one direction and the money in another. I think then you'll have to go with the votes. So really, it's up to the public, and I do think the public is starting to understand what's going on.
If people understood what you just described in terms of the sort of the values inherent in our healthcare system, and we failed to do anything about it once those are clear, I think it's a very, very dark reflection on our society, and it would mean that we are willing to utterly sacrifice and mortgage our children and grandchildren's future to avoid having to make any difficult choices ourselves. In my heart, I don't believe that that's where the American people are, but I'm not sure that there's so far a lot of political leadership to pull them above that.
The next part of our program is a presentation by our two panelists. I also would like to remind attendees that cards are available, I believe, and several volunteers will be sort of looking for a show of hands. If you're interested in writing a question, submitting a written question, just raise your hand and they'll see that you get one, and you can do that throughout the presentation, because I'm sure questions will come to mind as we progress with our discussions. I now would like to welcome and introduce our panelists. And if you like, you may take your places up at the table. Courtney Hederman is the Associate State Director for AARP Illinois. She is leading projects on healthcare reform and working on AARP's national campaign, Divided We Fail. AARP is a not-profit, nonpartisan membership organization that helps people 50 and over improve the quality of their lives. Founded in 1958, AARP has grown to 40 million members. It is the nation's largest membership organization for people of 50 years and older. And Jonathan Vanderbrug is the Healthcare Justice Director at the Campaign for Better Healthcare. He will explain his organization's work in the area of healthcare reform. The Campaign for Better Healthcare was founded in 1989 and is the largest healthcare coalition in Illinois. It is comprised of over 300 local and statewide organizations, including Catholic Charities, Church Women United, Illinois Nurses Association, Lake County Health Department, and University of Chicago hospitals. The campaign has received financial funding from many foundations, including the Chicago Community Trust, the Prince Charitable Fund, the Field Foundation of Illinois, and Robert Wood Johnson Foundation. I think we'll have Jonathan, you'll begin, and then Courtney will give the second presentation.
Sure. Can everyone hear me all right? Yeah? Is this better? Yeah. It's good to be here tonight. When I walked in the room and saw this, I was afraid I was going to have to sing, which wouldn't solve the healthcare crisis or your experience tonight. But no, it's good to be here. My name is Jonathan Vanderbrug, and I'm with the Campaign for Better Healthcare. As was said, we are the largest state-based coalition that works for healthcare reform. We've been doing this for 20 years, and yes, it's been an issue for 20 years and longer. But we're at a unique point in our nation's history with respect to the opportunity that we have for healthcare reform. And so it's good to be here with Courtney. We should start a consulting firm because we're on so many panels together. I feel like, but it's good to be here, and I thank the League of Women Voters for having me. The Campaign for Better Healthcare, we believe in, and I'm especially interested in your questions, so I'll try to remain at least relatively brief. But we believe that ultimately dealing with a healthcare crisis is a shared responsibility. Does government need to do more? Yes. Do individuals need to do more? Yes. Does business need to do more? Yes. We believe very strongly that if you live in the United States, you live anywhere, but you should be able to have some peace of mind when it comes to healthcare, that the healthcare that you need is there when you need it, and that you don't have to go bankrupt or lose your life savings just because you became sick. And when it comes to health care decisions, that should be a decision between you and your doctor. And it shouldn't be made by an insurance company that's basing whether or not you get care on insurance industry fine print, which shows that they can deny you for a lot of reasons. What we're ultimately going to get, I think, out of this is a uniquely American system, one that's based on that shared opportunity. And when we have questions tonight, I think we can talk a little bit about some of the bills and legislation that is before Congress right now and some of the strengths and weaknesses of those bills. I do want to talk a little bit about the video and also give our interpretation about why this has been going out of control and will continue to go out of control if we do nothing. They mentioned a couple things: technology, tort, fee-for-service, primary care, a number of those things. I can talk and pour water at the same time. Do you impress? But I mean, I think that there's some truth in a lot of that. There are some things that I might quibble with. Technology can be a source of costs going up. However, it can also be a source of controlling costs. Tort reform, I think, is important. You're finding that the administration is doing some pilot programs around tort reform. The reality, though, is it's not a silver bullet. If you expect to do tort reform and to solve the healthcare crisis and control costs, it's ultimately probably not going to do the trick completely. So do we need it? Do we need to look at it? Yes. But ultimately, when you look at the larger costs of healthcare that's burdening our system, ultimately medical malpractice is about 0.6% of the ballooning of costs to deal with this. So do we need it? Yeah, we need to look at it, but it's not the silver bullet. Certainly primary care is important, and dealing with fee-for-service is also important. But one of the things that, or actually two of the things that I want to focus on with respect to what the video showed was, one, how this crisis is affecting the insured, people who do have insurance. And secondly, what I think is one of the biggest drivers of healthcare costs that the movie did talk about, and that is insurance company profits, which are disgustingly high if we're honest with each other. This is not just a problem of the uninsured, although it is dealing with the uninsured. There are now 50-odd-some million people who are uninsured. And when you look at, when you define kind of being uninsured as someone who, when you look over the last year or two, has been uninsured for 6 months or so, or for a month or so, that number goes up a lot higher. I don't have the statistics with me, but I think you start getting to 1 in 5 or 1 in 4 when you ask people, okay, you have insurance now, but over the last couple of years or in the next couple of years, will there be a period of time when you're uninsured? And that number tends to go up. Right now, if you have insurance and you don't want to deal with this issue, then you should go to your ATM and withdraw $1,100 and burn it, because that's how much is going in your insurance premiums every year because we're not dealing with this issue. On average, $1,100 to $1,300 of insurance premiums in Illinois are a direct result of cost shifting from the uninsured. We also believe that prevention is key, and when people don't have access to insurance, they're forced to oftentimes rely on the ER, which is the least efficient way to deal with things. On Saturday, I actually met a gentleman and was talking with him, and his wife, they were uninsured, and his wife got very sick. And they called the doctor. She was having a hard time breathing and had a lot of congestion. He said, I know you're not insured, but this worries me a little bit. Go into the ER. They went into the ER. They waited a very, very long time. And they were finally able to be seen about 6 hours later. And the doctor, who was very rushed, said, it looks like you have a bad cold, prescribe some antibiotics, go back and deal with it. It just got worse. 2 weeks later, they went to the ER again because it was getting worse. The husband said, I just lied and said we had insurance and tried to fudge things. They were able to get care, and she had double pneumonia. She then went into a coma, and she died 3 weeks ago. This is a gentleman who has worked all his life. He's paid his taxes. He was employed full-time in a professional engineering job. Okay? And his wife, he believes, lost her life because she didn't have access to care. And he and his son, who's 3, are going to have to deal with that their whole lives. And that's not the way this is supposed to be. His family pays for it, and we all pay for it. The second thing that, in addition to the cost shifting that I want to talk about, is insurance company profits. Right now, Illinois is the wild, and check me on time. How am I doing on time?
You're okay, you're fine.
Okay. If there's a big hook that comes out, let me know. This insurance company wants to hook me sometimes. Illinois is really, in many ways, the Wild West of insurance regulation. If you're an insurance company in Illinois, you can do anything you want for the most part. As an insurer in Illinois, I can look at you and I can try to determine your age, and I can charge you anything I want to based on your age. If there's 2 people here, one is 60 and the other might be 40 or 35, and they may have similar medical conditions or similar medical history, live in the same neighborhood, live in the same condo building, who knows. I can look at the 6-year-old and say, I'm going to charge you 3 times as much, 4 times as much. And I can say, why are you, and the 6-year-old may say, why are you charging me this much? And they can look you square in the face and say, because you're older. That's perfectly legal, and it's done all the time. It's called age rating. They can also charge you more if you're a woman. You can have a very similar medical history as a man. They can simply look at you and say, you're a woman, I think you should pay 3 times more. They're perfectly in line to do that. If you have a pre-existing condition, no one ever has to cover you, ever. If you have grandchildren or children or siblings or friends that have a pre-existing condition, they're frankly out of luck. No one has to cover them. And what's more is you can pay all your premiums, okay, and you can pay all your costs on time, and you can be approved for a medical procedure, and you can even get that medical procedure done. But, and they pay people to look for this, if they find something in your history that you did not report, they don't have to pay you a cent. We had a woman who called our helpline. She needed surgery. She paid her premiums on time. I think she was with the insurance company for 5 or 6 years. She needed to have a surgery. She received approval for that surgery. She had the surgery, after which the insurance company sent her a letter saying you had a severe rash 2 or 10 years ago. That was a problem. You didn't report it. You lied to us. Therefore, we will not pay for the surgery. And she's $70,000 in debt. That's perfectly legal right now. And it's that type of thing, which is driven by profit, which I think the movie has right, that should simply not be in that system. The 2 executives of Blue Cross Blue Shield Illinois last year retired, and they received a combined exit bonus of $26 million. That would have provided coverage to 3,100 families in Illinois. The bureaucracy in the insurance industry is tremendous, and I won't get into that because the movie did refer to that. But right now, there is no one holding the insurance industry accountable, and we all pay for that. We're all paying for that, either directly, some of us, or through our friends and family getting denied care, or through tons of people getting denied care who are then forced to go to the ER, and we pay for that cost. As the Campaign for Better Healthcare, we do believe that, as I mentioned, that a single-payer system is ideally the best way to go. If we had to write up the ideal system, that's the way we would go. However, we know, as the many factors that they stated in the movie, that ultimately we're a unique society and we're going to have to find a uniquely American solution. So one of the things that we feel, and I'll kind of begin to wrap things up with just this one policy part, is that legislation, as it takes its different forms between now and the next 2 months when something has to be done, we do believe that it should have a very strong public option. Not a lot of the gimmicks that are talked about, but it should have the choice of a strong public health insurance plan. We believe that choice is important, and that American families and people of all ages should have the choice to keep what they have, the choice to go with another private plan, or the choice to go with a quality public health insurance plan, and that competition is good. That competition of a nonprofit entity in the market can actually help to keep the insurance industry honest. When the insurance industry has sometimes 15 to 20 to 25% overhead that goes to marketing and profits, you need another entity in the system that doesn't worry about profits, to hold them accountable, to make sure they spend more on care and less on profit. In terms of, when you look at states, and you look at each state's 2 biggest insurers, so you look at the 2 largest insurers, how many states do you think have markets where those top 2 insurers don't control the majority of the market? So for example, let's say you have Blue Cross Blue Shield and United Healthcare. And those are the biggest ones in the state. In every state except 3, the top 2 insurers control the majority of the market. That's not competition. In Illinois, if you look at the 2 biggest insurance companies, they control over 70% of the market, a near monopoly. And that's got to stop. And when you have the choice of a quality public health insurance plan, you're able to deal with that. So that's something we're looking at very closely as a key to driving down costs. And I would end with where the movie ended, and that is, you do need to call your congressperson. This ultimately, I believe, is not a policy issue. When it comes down to policy, the research has been done, and I think in general we know what needs to be done. It's a political issue. It's a matter of political will. And it's right. They're right in the sense that, and I'll be cynical here, but politicians are scared of one thing: losing their job and losing their power. And they need to hear from you. We have a number of ways that you can get involved. I have some handouts in the back. One of them is blue. That talks about 3 C's, which we would call call. C, call your congressperson. Canvass for a little while over the next 3 weeks, maybe an hour, and also contribute to the cause. And I have a sign-in sheet in the back if you would like more information. But if you do care about this issue, if you care about your own health insurance, that of your children, grandchildren, and friends, this is an incredibly important time.
Thank you, Jonathan. I'm going to turn over to Courtney for her presentation.
Good evening. How is everyone? Healthy? Oh, that's good. I just want to thank the League of Women Voters for inviting me here tonight. I truly am honored, and it's a privilege to be here. I am from AARP. And actually, somebody had asked about, is AARP stand for the American Association of Retired Persons, which is what it used to stand for, and it no longer does. It actually just stands for the letters AARP. We have 40 million members across the country, and about 90% of them are still working. So thus, they are not retired. So we more or less changed our name to include it just being the letters AARP. So obviously, as most of you might know, we're a national organization. We do have 40 million members. We have 1.8 million in Illinois. We have 2 Illinois offices, one in Chicago and one in Springfield. So we do obviously state advocacy work as well as federal advocacy work. And just a brief tidbit about our history. We were created a little over 50 years ago by a woman by the name of Dr. Ethel Percy Andrus. And she has Chicago roots. She went to school here at the University of Chicago and actually became a teacher and taught here for quite a while. She moved to California to take care of her ailing parents and became the first woman principal for the state of California. And then after she retired at the age of 68, she created the National Retired Teachers Association. And the main reason was because she had run into a colleague of hers that she taught with, and this woman had a catastrophic illness and had lost everything she owned, including her house, and was literally living in a chicken coop. And Dr. Andrus was horrified that retired teachers did not have some sort of health care coverage. So she started NRTA really with the goal to have retired teachers have some sort of coverage. Well, as you can imagine, and that did happen, she heard from people across the country saying, you know, bravo, that's great. I really think that's wonderful, but guess what? I'm not a teacher, but I still want retired coverage or healthcare coverage. Can you please help me? And so she created or established AARP 11 years after that. So at the age of 78, she started AARP for that exact reason, to have retirees have healthcare coverage. Now, the reason why I'm telling you this is because that was over 50 years ago, and we're still talking about healthcare. AARP is, from its inception, really felt strongly about healthcare coverage for all. And obviously, our membership is 50 and older, so we definitely have a priority to the over 50 population. And so, contrary to reports, AARP has not endorsed any proposal that is in Congress, and I have to say that at every single panel that I'm on or event, because there was so much misinformation that AARP had endorsed and supported specific pieces of legislation, and that's not true. We are absolutely supportive of healthcare reform, not only for our members, but of course our members' families. So we are very much immersed in the issue and potentially could endorse something if there are certain things included that obviously would be beneficial to our members and of course their families. So I wanted just to quickly talk about those few things that are priorities for our organization, specifically for our members, and then I'd much rather stop talking and hear from you and answer any questions you have. So AARP's position in the sense of specific priorities that we have. It doesn't take away from all the issues that are out there, because of course there's multiple ones that we are supportive of or certainly interested in, but these are definitely the primary ones that we're very concerned about. One is strengthening and securing Medicare. There have been a lot of harmful, very mistruths out there that talk about Medicare is either going away, that there's dramatic cuts to Medicare, that people are going to lose their benefits, and that's absolutely not true. But that does not mean that Medicare is completely safe, and so we want to make sure with whatever final proposal there is, that there's actually strengthening and improvement to the Medicare program, specifically in a couple of areas. One is obviously some containment to premiums, specifically now with the Social Security Administration not having a COLA, a cost of living increase. We want to make sure that premiums stay affordable, obviously. In addition, just protecting the benefits. So when you hear that there's benefit cuts, we want to make sure that there are no benefit cuts ultimately. Now at this point, in all the proposals that are out there, there are not benefit cuts. And I don't really see any political will that would.
If we could hold and could you hold your comments till she finishes her presentation, and you're welcome to submit.
Yeah, that's, and we can talk about what the cuts are to the Medicare program, but not the Medicare benefits part of it, because there are Medicare cuts, but it's not to the benefit side. So I can definitely talk more about that. And actually, let me just address that because I'm sure it's going to bring this has obviously brought that question up. There are not benefit cuts. The cuts to the Medicare program are in fraud, waste, and abuse, which basically translates into phony patients, double billing. There have been many scandalous type of situations with hospitals and physicians that have really made a detrimental mark to the Medicare program. They want to contain any fraud, waste, and abuse that takes place in the program. In addition, there are Medicare Advantage plan cuts. Now, most of us in Illinois and anybody who's on the Medicare program does not have a Medicare Advantage plan. But the states like Florida, for example, are very heavy in a Medicare Advantage plan option. And really what Medicare Advantage plans are is the Medicare program, or the federal government really subsidizes a third party to manage a system for that coverage for somebody. It's to the cut to that particular program, Medicare Advantage, is to eliminate that third party, not subsidize it, not give those third party payers any more money than they already have gotten. So it's to minimize that piece and not ultimately reduce anybody's benefit, actual care benefit. So ultimately, AARP certainly wants to preserve Medicare and strengthen it ultimately. The other piece, besides obviously protecting the program and whatnot, is in around the prescription drug plan program. And more importantly, obviously, to contain and lower costs of prescription drugs, but ultimately eliminate the donut hole, what we affectionately call the donut hole, where individuals are paying 100% of their drug cost. That is absolutely absurd. We want to see that completely eliminated ultimately. In addition, there are specific classification of drugs that have no generic equivalent or pathway to become a generic equivalent. For example, a classification of drugs called biologics, which are drugs for certain cancer patients, people who have rheumatoid arthritis, those that have MS. They are needing brand name drugs called biologics that are extremely expensive. We're talking $10,000 a month. That's how expensive they are. Well, you know what that means. Someone doesn't necessarily be able to afford $10,000 a month for prescription drugs, so they ultimately don't take the drug, and of course their illness is to the detriment. So really, we want to make sure that all drugs have a pathway or classification to become a generic equivalent. The FDA, the Food and Drug Administration, has an actual procedure and the film talked about it, where a brand name drug goes on the market, has to stay on the market so long as a brand name before it can become an actual generic. There's certain classifications of drugs that don't have that authority. So we obviously want to make sure that for those individuals that need those types of drugs, that they have them. In addition, there are plenty of preventive care, wellness type of benefits that Medicare beneficiaries need, and they really, we believe, should not be having any out-of-pocket expenses. So, any deductibles, any cost sharing, anything that, any additional premiums for any wellness or prevention, we want to see eliminated. And actually, several proposals actually do that. In addition, and there was obviously a skew to the film in the sense there was a lot of physicians talking, and I would be remiss if I didn't mention AARP is extremely supportive of physicians being paid adequately and fairly, specifically primary care physicians. People need to have a medical home, so they're not going to emergency rooms. Those are obviously for the uninsured, but even those that do have insurance, we want people to go to primary care physicians so they can get those wellness and prevention screenings and ultimately maybe catch something in an early stage if in fact it is something that could be quite catastrophic ultimately. So ultimately preserving someone's choice of a doctor, making sure that if you want to see a specialist, you want to see a specific doctor, you as the consumer, the patient, however you want to see it, you have the right to choose that physician, and ultimately they should get paid in an adequately fair way at the same time. The other piece, which Jonathan made, I think, quite a few remarks, so I won't spend a lot of time, is really preventing discrimination towards anyone, regardless of their health or their age. So in the health situation, obviously, making sure that people are not denied any insurance or coverage because of their health, any pre-existing condition, those clauses should be absolutely eliminated. And in fact, most of the proposals out there do just that. But in addition, the age rating, which Jonathan also mentioned, is definitely a top priority for us. Our position is a 2-to-1 age rating, so no older individual should be charged more than 2 times a younger individual, and that includes obviously no matter what anyone's gender is as well. So we want to make sure that no matter what, there is no age or health discriminations. In kind of lastly, and then we can talk about the status of the particular legislation that's out there. We are very much in favor of long-term care funding, for lack of better words. Long-term care in the sense of home and community-based services. This is not to take away from any nursing home, facility, institution, care. We want to actually just see more dollars go into home and community-based services. It's really to level the playing field, because we tend to give a lot of money to nursing homes and certainly not quite even close amount to home and community-based services. It's really just to allow people to have choice, that if they want to be in their homes and communities independently, they need to have services and care to allow them to do that. And we want to make sure that if somebody wants that, then they have those services available to them. There are several pieces of legislation that's currently in the House and the Senate, and it is moving very fast. I can at least pretty much briefly talk about that. The Senate Finance Committee actually released today, they had the chairman's mark, which is Chairman Senator Baucus, released his version or his proposal almost 2 weeks ago, I guess, and there were 567 amendments to that bill. And surprisingly, in a week and a half, the committee has gone through those 567 and either voted yay or nay, or however they wanted to do it. And they are now in a situation they're ready for the committee to actually go for a vote. And then if that is voted in a positive way, then it would go to the Senate floor for a full vote. The idea is that the Senate wants to go and have a full vote before or during the Columbus Day recess. They usually recess that full week, but the Senate has already released their calendar saying, oh no, we have lots to do and we need to be here in Washington and not be going home. So they will only be home for 2 days, the Friday and the Monday, and then they'll be back in Washington, and the plan is for them to vote on whatever version obviously they vote on. Right now, the committee, they were supposed to vote tomorrow. That was extended to later in the week because I don't think they believe they have the votes, even from the Democrats. And so they are working and ironing out a few details, I guess they want to make sure. On the House side, which is what the legislation most people are very familiar with in a way, is that H.R. 3200, which was 1,018 pages and cost $1 trillion. Then during the August recess, that's when people were just having town halls and people were extremely angry and upset. And the House is very much in a holding pattern. They wanted to see what the Senate was going to do. And so Speaker Pelosi has not given a timeline quite like the Senate. They're in the situation where they're still trying to determine how they're going to pay for their version of what they want, and so they're in the situation where their timetable is a little bit further along, and they haven't even been as clear about what they're planning or what they're doing. Some have indicated they do not want to go be in the situation to vote for that H.R. 3200, and so we will certainly see what the House does. They are in a way a little bit. I think they're out of the gate. They were very fast. And now the Senate is the one that's kind of, I think, faster, and I think ultimately they're going to go to a floor vote before the House even gets a chance. So that's kind of the status on where things are. Obviously, the President has already made reference to wanting to have something before the end of the year on his desk so he can sign. So I think that they are ultimately working on that type of timetable, and it is a very fluid situation, ever-changing. And I think both Jonathan and I, as immersed as we are, we're happy that we're here to take, and certainly to take questions and go from there. So,
okay.
Thank you.
As you all know, we've selected the written format for questions tonight, basically because what we find is there's often much redundancy in the questions, and in order to provide a good balance, we can often combine questions. Hopefully we'll get to everyone's questions. So, several of the questions, Courtney, are directed at AARP. One of them, and I'm going to kind of combine these questions, one of them cites the fact that AARP does offer a form of health insurance, and they're wondering if people can be turned down. And the second one is a question regarding whether there's a business relationship with United Healthcare and AARP, and would seek your comments on that. And also talking about whether your organization has not supported a single payer plan or even a strong public option, and a response to that. And then a question raised about the money being raised for, the money being raised for lobbying Congress. So there's a bunch of things,
Okay.
but they're kind of all a little bit related. So if you
Sure.
could kind of respond to that, please.
Sure, yeah, there's quite a bit there. I'll try to answer them all. One is, we, as an organization, AARP is kind of like a three-legged stool. We have the state and national initiatives, which is basically our advocacy on the Hill as well as our state advocacy. So that's definitely a not-for-profit arm or leg, if you will. In addition, then there's the AARP Foundation. So that is also the other not-for-profit side of us that, we are in the communities giving back grants and all sorts of things as a foundation, as a very kind of traditional foundation, as you might think of. The third kind of leg is the services, and that is if we're a membership-based organization, and very similar to AAA, we offer our members specific types of services or benefits. And one of those types of benefits is healthcare. And so we have contracted with a vendor. We did an RFP many moons ago, and United Healthcare was the organization or company that we ultimately have a partnership with, and they are the ones that then ultimately provide that healthcare coverage to any member who chooses to partake in that. United Healthcare has their own set of policies and procedures, and so, in the sense of are people turned down, there are clauses of really specific types of pre-existing conditions that could, be in a situation where they're not approved or allowed to, get the insurance. But we work very hard with United Healthcare to make sure that they don't do that. But ultimately, United Healthcare has their own set of policies and rules. And yes, we contract with them. We're a partner with them. But we don't ultimately control everything United Healthcare does, even though we probably would love to at times. So that we have a process in how somebody, though, becomes one of our vendors. And so, again, it's an RFP situation, and our board of directors ultimately chooses whoever that contract or partnership should go to. So that's kind of our United Healthcare relationship. And, we're consistently trying to add benefits that our members certainly will be happy with, and they're obviously, legitimate, fair, quality partners. And so compared to others, the board of directors chose United Healthcare. In the relation to not supporting single payer in a public plan, we actually have never said we don't support those proposals or policies. We have not come out strongly, I will say that much. We've kind of in a way remained pretty neutral on both of those types of issues. I will say our president, though, of the board, did say in a Senate hearing that we would absolutely support a public option if it incorporated a couple or several guidelines or things that we thought were very important. One or several pieces being that it was affordable, that it was quality, that it did not hinder any access, and so I think we could actually support a public option if the details came out and we thought it would obviously be helpful for people. We are absolutely all for choice. Yes, we provide health insurance, which I think some people think that it's a conflict of interest, and I would say that we are not obviously the provider of the insurance, but we contract with somebody, so that's a benefit for our members. But we're all for choice. In fact, we have many tools that go to the most inexpensive, the one that a company that provides, whether it's prescription drugs or medical coverage, go to the one that's least expensive, that gives you the best bang for your buck. That's AARP and our vendors. That's great, but if it's somebody else, that's better too. So we're all for choice and for people having the best option for them. The lobbying Congress piece, the way our funding stream is obviously we have dollars that is raised through our services side, so those that do have our insurance or those that do have automobile insurance or other types of things, obviously there's revenues generated there. There's also revenues generated from our membership actual fee, which is now $16 annually. So there is money generated in multiple ways. Our foundation is very separate. We do not take money from our foundation that is strictly to finance grants and other things for communities and projects. So as far as us lobbying Congress, we have a budget for that. I actually don't even know the exact amount, but I could certainly find out if anyone is specifically interested.
And Courtney, perhaps you could follow up if anybody wants more information about this. We have so many questions tonight. And I'm going to ask a terribly challenging thing of our panelists, and that is I'm presenting complicated questions, but I'm able to answer as many as possible if you can give brief answers, and perhaps people can follow up with you afterwards if they want more details. This one was directed to Jonathan. How do you reconcile the claim that tort reform amounts to only 0.6% of the U.S. healthcare costs when others have reported tort reform would save $200 billion or more annually?
What's the statistic that was quoted by the questioner?
$200 billion or more annually.
I don't know. I can provide the citation for what we provide. I think the question is, what are you looking at in terms of costs? Again, we think tort reform is something that's needed, but it's not a panacea. It's not going to solve the problem of the healthcare crisis. You can't say in one breath that doctors charge more or that doctors order more tests because they want to make more money, and then at the same time say that malpractice reform is going to save costs. Because there's been several studies, one in Texas, I forgot where the other state was, where they did a pilot on malpractice reform. It did lower malpractice premiums somewhat, but savings were not passed on to the customer. So you not only have to prove that malpractice will reduce costs, but you then have to prove that the same profit motive, which you say doctors use to order more tests, doesn't apply, and all that savings will be passed to you. So you got to go one way or the other. Again, is it important? Yeah, it's something that needs to be looked at, but you're not going to deal with this problem only through malpractice reform. You're going to deal with the problem by giving American families a choice of providers that they want and holding insurance companies accountable.
You know, I just have one comment. This is, I think, my 26th panel since August 1st, and I am not even joking when I say this. If there is one theme and one particular issue that has crossed every single one that I've been, it is tort reform. And I was with the Chicago Medical Society for several of their panels. In fact, the doctors were in Washington today meeting with the administration, and the #1 issue for them is tort reform. I would definitely argue that to have very meaningful, comprehensive healthcare reform, which is what we're talking about, we have to have some sort of tort reform, or we won't go forward in, I think, the reform that everyone certainly wants and that they're talking about.
Thank you. We have two questions that sort of address the idea of our free enterprise system and our freedom of speech. One has to do with making insurance companies more accountable. Does this in any way affect our free enterprise system? And the other question had to do with the disallowing of mass marketing of drugs by the pharmaceuticals. Isn't this a free speech issue? If you could briefly comment on those two questions.
In terms of enterprise, I don't think we're fostering enterprise. If someone wants to start a small business, they're not going to do it. They're going to stay with a dead-end job because they don't want to lose their health insurance. The number of small business owners or would-be small business owners that come up to me afterwards and say, I have the skills, I have the knowledge, I have the experience, I have the drive to start my own small business, to be an entrepreneur, which is at the heart of the entrepreneurial system. But there's no way I'm going to leave my job and leave my family uninsured. So if we want to have an entrepreneurial system, we must have healthcare reform. And we must have healthcare reform that provides true competition. An entrepreneurial system, in my mind, is not a system in which you have two large for-profit corporations controlling an entire market and telling you whether or not you get care. That's not free enterprise, in my mind. And so you need to have efforts and drives that free up competition, that cause competition. And that's why we feel the choice of a strong public health insurance plan is absolutely vital of that. One thing I'll add in addition to that is if you want to talk about entrepreneurialism, healthcare costs are killing our businesses. I spoke with Martha, who owns Timeless Toys. She and her husband own Timeless Toys in Lincolnwood. It's a great place. I go there a lot, supposedly to get toys for my son, but they're really for me. But I talked to her, and she said, you know, my insurance broker came to me with good news 3 months ago. And he said, you know what, your premiums are only going up 17% this year. They went up 22% the year before and 23% the year before that. Why? She only employs 8 people. Now she's saying, when I sell a teddy bear, I'm not making 18% profit. The majority of our economy runs on small business. And unless we free up small business owners to focus on what they do best, which is business, they're not going to succeed. And they need to have the choice of a public health insurance plan to buy into. Now, in terms of free speech, in terms of marketing, I'm not a constitutional lawyer. I know the Supreme Court opened today. It was passed, and I think that, I have a pen. I didn't bring it with me, but it was produced by a drug company. It has the name. Actually, this is where I get most of my pens. Free pens from drug companies. It has a cap to it. It's by some pharma company. You click it and it turns orange. You click it and it turns red, you cook it and it turns blue, it glows in the dark, has wonderful ink in it. I'm not sure if Thomas Jefferson envisioned that as free speech, you know, the right to do that. And besides, I don't want to pay for that. I want to pay for medical care. I don't want to pay for pens that just attract business for people so they can earn multi-million-dollar profits. So.
If you don't mind not commenting on this, I could introduce another question, and we'll let you respond first if you'd like. We've heard about outcomes in comparison to fee-for-service. How would the outcomes approach work, and how could we get closer to the models of the Mayo and Cleveland clinics? And Courtney, we'll start with you.
That's a hard question, Courtney.
It is a hard question. Do you want to give it to Courtney first? Okay. Sorry,
it's a good question.
It's a very good question.
Excellent question.
I guess in regards to outcomes, you know, there is, at least within the proposals the way they're currently in their current form, you know, there is a lot of, you know, I guess concentration on wellness and prevention. And the idea is for then ultimately people to have healthy outcomes. And if people have the education and knowledge, you know, knowledge is power, you know, they'll make smarter choices in their diet and, you know, exercising and going and getting their annual physical and things like that. And ultimately, they're thinking in the long term, if you put money out front in preventive care and primary care, then the long term, people will have healthier outcomes. People could argue that it doesn't matter. Sometimes the luck of the draw. You have, you know, family history, genetics, and you know, you have a family history of, you know, high blood pressure or cholesterol, and it doesn't matter. You could do every possible thing, eat the best food on the face of the planet. You exercise every day, and it still doesn't matter. Your cholesterol's, you know, 250. So I think, though, on average, though, that the idea is for people to have healthier outcomes, and if that is the way to do it by prevention and wellness and educating, then that's certainly, I think, a lot of people's thought process. The proposals go into quite a bit of detail in trying to promote that type of thing, and obviously AARP would, you know, is and would be supportive of that in a final package. So I don't know if there's other parts to that.
Yeah, I mean, I would just add
That's just
to it.
one
Yeah,
part.
there's a couple concepts. One is they mentioned briefly in the film, and that is of a medical home. This radical idea that doctors should talk to each other. Medical home basically says that care will be coordinated kind of at a home, that there'll be a physician and a provider that will follow you and help coordinate care. The other is comparative effectiveness, which a lot of doctors, including the AMA, strongly support. And I should note, by the way, that the AMA strongly supports the reform that's been proposed. I mean, they strongly support the reforms that Obama has put forward, which includes a strong public option. I would also add that 62% of doctors support a strong public option. So the physician community is very much behind this. But comparative effectiveness basically says, let's have medical professionals look at some of the data, look at what works in terms of treating certain conditions under certain circumstances, and then kind of set that forth as a guide. It's a guide. If doctors want to go another way, you know, they can get into, they can do that. But it's trying to base outcomes and pay based on performance rather than on the number of tests that are ordered. So.
Okay. Two questions related to physicians. One, I think you've already partially answered, and maybe you can acknowledge that. Would one be able to continue to have his or her present physician with a national health plan? And how would a person or a family purchase services who has a very low income? Would each person be compelled to buy insurance? And the other one related to doctors, is it true that doctors are behind the public option? So that's kind of, let's get all our physician comments out of the way.
Yes, no, yes. Yes, absolutely. You'd be able to keep your doctor. I think one of the scare tactics, and that's the opponents of reform who want us to do nothing because they're profiting off of it, make that one scare item. Absolutely. You'd be able to keep your own doctor and have your own choice of doctors. So I think that's the most important thing. How would someone who's low income be able to get care? Depends on the legislation that you're looking at. Most of the, and by the way, there's 5 committees that either reported or are reporting out bills. So, and out of those 5 committees, 4 propose a strong public health insurance plan, and the other is the Senate Finance Committee. In terms of, yeah, and the 5th one's wrong. But in terms of how people with low income would get care, it usually involves kind of a 2-tier or 2-part system. One is an expansion of Medicaid, so that people who are very low income, for example, right now, if you don't have children, you will not get any public support at all for health care. You could be earning $2,000 a year. Under federal law, it's a categorical denial. You don't have kids, you don't get assistance. The bills, I think, almost unanimously, even in the Senate Finance Committee, would take away that exclusion. So even if you don't have kids, you earn 98% of the federal poverty line or less or whatever, that you would get care. A lot of it also involves what they, is a sliding scale up to a certain point, and that's being debated right now in Congress. But to say that if you're of lower income, that you will receive subsidies from the federal government based on your income. It could be $1 if you earn higher, it could be more if you earn less, and you will be able to use that subsidy in what's called a health insurance exchange, which consists of private insurers competing with each other on basic standardized plans. So you can look, this gets kind of detailed, but you can look at the health insurance exchange, which again, by the way, every single plan, all 5 of them have. The health insurance exchange is basically a marketplace. It's like a farmer's market. You can go, and instead of having a bazillion plans to look at, and some of them cover this and some of them don't cover that, you'd actually have some standardized packages that you compare based on price. And people who are not very low income but are lower income, in most of the bills that have been proposed, would be given sliding scale subsidies. They'd still be expected to do their part, but would get sliding scale subsidies to go into the exchange, choose the plan that works for them, and choose that plan. Now, what we believe is that in that exchange, part of those options should be a public health insurance plan. So if they want to go with a private plan, fine. If they want to go with a public health insurance plan, they can choose that as well. Our fear is that if you give families subsidies and they go into an exchange that only consists of private insurers, that's a wonderful deal for private insurers. Now you have more government money going to boost the profits of the private insurance company. That's just wrong. If you add an individual mandate to that, now you're forcing everyone to give business to the private insurance industry. If I'm selling microphones, I would love it if the government mandated that every household in the United States had to buy a microphone, right? And then they gave every family, then they gave families subsidies to go buy microphones from me, and there was no public entity that would compete with me at all, forcing me to keep costs down. So, an individual mandate is something to look at, but we don't believe you can have an individual mandate unless you have affordable products out there. You can't force people to buy something that's not affordable, and you're not going to get that affordability unless you have competition.
Courtney, do you want to add anything to that?
Yeah,
We've
just,
got I'd like to cover about a couple more questions.
Nope, just very quickly. In relation to, wait, the first part of the question was regarding
Keep your doctor.
Keep your doctor, yes. Thank you. There were so many the facets to that.
That's right. I know. I'm crunching.
In regards to keeping your doctor, I was on several panels for the Chicago Medical Society, and even with the doctors being on the Hill today, they've been very open about being paid fairly and adequately, and they're in a situation where there's a 21% cut to their reimbursement, except for primary care physicians. They actually have an increase. And several proposals actually minimize or reduce that cut for 1 year. So it's like they basically have a year off and then they get the 21% cut. Physicians obviously are very upset about their payment system and how they are paid, not only through Medicare but also in private insurance, but specifically through the government and how they're reimbursed is a little bit, it's very convoluted, and they're definitely fighting pretty mad about that particular piece. Why I'm mentioning this is that they necessarily haven't threatened that they would refuse to take patients, but that's the fear. And the way certainly the intent and goal of healthcare reform, and specifically what we're talking about, is that people have the option of whatever physician they want to see. Now, of course, if doctors aren't paid fairly and adequately, then they could maybe choose to opt out and not take specific types of patients. That is why we want to see them paid fairly and adequately, whether they're a primary physician or a specialist. We want to obviously eliminate anyone who's fraudulently or abusing the system. But ultimately, that doctors being paid fairly and adequately and timely, we would hope then they are going to accept patients, as many as they can obviously fit in a day. The very last piece I'll mention is the AMA did come out and support HR 3200, but I supposedly during their board, when they made the vote, the public option and public plan was off of that. And so some people within the AMA have said we don't support a public option, and others feel very, very supportive of it. And so I think my sense is, no matter if someone's a physician or not, the way the proposals are, there's some proposals that have a public option and those that don't, specifically the Senate Finance. That is going to be probably the biggest issue, if not the top three. But if I have what I think is going to happen is the #1 debatable issue when Congress comes together on some sort of final package is if there's a public option or not.
Okay.
I just one quick thing to add.
Okay, very quick, because we're running short on time.
I think you would see if the AMA came out in favor of something and they realized that it wasn't what they came out in favor of, they would have said so. So I disagree. I think doctors are strongly on board. I think it's a mistake to think that physicians en masse are going to say they don't accept this. If that was the case, Medicare would have shut down right now. That's not the case at all. So I think that's basically an unrealistic fear that you're not hearing from physicians. That's why 62% in number of polls that you read support the public option. You also have to realize right now there's a lot of physicians and providers that are getting 0% reimbursement for patients that come in. Providers are facing hundreds of millions of dollars in uncompensated care because people don't have insurance, and they're getting 0% reimbursement right now. That's a pretty bad reimbursement rate as far as I'm concerned. A lot of that will be dealt with. They won't have to carry those burdens of uncompensated care because people walking through their door actually have insurance. That's a good thing. I think that's why you see the AMA on board with this and with the public health insurance option. That's why you see the vast majority of doctors backing this. And we've actually seen that grown, and you'll see it continue to grow, I think.
Okay, we have the dilemma tonight, as I said, of very complex questions and complex answers, and it's put a pressure on all of us. Fortunately, we do have time constraints, and there will be several questions that are related to ones that you've already answered. But if you feel that your question wasn't answered, please come up and speak to the panelists about it. I'm going to close with one final question, and I'm going to say that I'm going to have to limit your response to a very short 30 seconds or less. Wouldn't it help to pass the reforms Congress agrees on and leave the disputed areas for later actions and discussion? We're going to pass the one to Courtney first.
Sure. I can take it.
No, that's okay. Courtney's turn.
I'll go first. If the questioner is leaning towards maybe there should be just pass what they can agree on and worry about these other big things later, meaning things are taking too long or things are going too fast, my only comment is is that if there isn't some sort of comprehensive reform on these very tough issues, that it's going to be a bazillion years till the next time. I think the time is absolutely crucial right now that there's something passed in a comprehensive way, because things have gone very much piecemeal really since the inception of reform. Look at Medicare, for example. We do things in a very incremental way. This is our chance to do something in a large scale. So yes, there's complicated issues that they still need to iron out, but if they don't do those, I think then we're not going to see something for a very, very long time, and we want to make sure that there is.
Jonathan, a quick answer from you.
In the next 2 months, the decisions will be made that will shape the structure of our healthcare system for the next 20 years or more. And the question in terms of what do we settle for is up to you. We need to pressure our Congress people to do the right thing and to be bold in their action. They won't be unless they hear from you. So there are ways to get involved. There's a blue sheet in the back, and I encourage you to do that and give voice to your concerns, and let's get this done this year.
On behalf of the League of Women Voters, I would like to thank our panelists and our audience for their participation. Informational materials from both the League and our panelists are available on the table at the rear of the room, and more information about the League's position on healthcare reform may also be found at our website, www.lwv.org. We do encourage citizens to contact their legislators regarding the importance of a public option as part of the healthcare reform plan. And thank you for attending this evening, and thanks again to our panelists.
Thank you.